already touched a little bit on fluids with respect to sepsis as we started this symposium this morning, but maybe antibiotics, maybe vasopressors, maybe corticosteroids, all of that there have been recent literature on in terms of introducing controversy in sepsis resuscitation. And to take us through that is our next speaker, so very happy to introduce Dr. Cami Hu. All of us in the room know Cami, but for those tuning in across the globe, Dr. Hu is currently an assistant professor in the Department of Emergency Medicine. She splits her time between the ED along with the MICU and is our program director of the program she completed, our EM/IM critical care program. So she's not only the program director of that 6-year track, but also our 5-year EM/IM program. So very happy to welcome Cami and take us through some controversies in sepsis resuscitation. My thanks, Cami.
All right, thank you very much for that introduction. Hello, everyone out there. It is always an honor to be included in the Critical Care Symposium. I'm glad to be here this year. I have no conflicts of interest, unfortunately. I have it pretty easy today, right? So we've already had Dr. Spiegel and his talk on fluids. We had a bicarb talk by Dr. Chan, and Dr. Sutherland's going to talk about steroids later. So today I don't really have to get into too much. I'm going to talk about reasons we may or may not want to use early vasopressors, methylene blue, even beta blockers in septic shock, and then what the data out there says as to, yeah, we should or no, we shouldn't. All right, so we're going to start with early vasopressors. And there's no real consensus as to what early vasopressors means. Nobody came together and was like, early means within the first 5 minutes. Usually if you look at the studies that exist, and there aren't really that many, it's around within an hour to 3 hours, sort of related to the sepsis bundles of shock recognition. So initiation of fluids for hypotension related to sepsis. Now, why would we want to start vasopressors early? Aren't we worried about clamping down on vessels that may be empty and worsening ischemia? Well, we can do this, right? The kind of standard practice, give a couple liters of fluids, maybe they get their 30 mLs per kg, MAP's still not quite good, so let's give them some more, and then if that doesn't work, then we'll put some pressors on. But if you think about it, sepsis itself, the pathophysiology associated with it, is really one of vasoplegia, right? There's endothelial dysfunction. Because of the bacterial infection, you have endotoxins circulating around. They are stimulating the body's inflammatory and immune response, and so you have all these cytokines going around, acting on the endothelium to increase the release of nitric oxide synthetase. Like Dr. Chan, I'm not going to get too nitty-gritty into all the little physiology stuff, but just bear with me a little bit. So there's an I on this nitric oxide synthetase to denote inducible. So nitric oxide synthetase is normal, your body needs it, but the inducible part is in this milieu, it's been stimulated. All right, and so nitric oxide, right, nice and normal. Again, it plays a very important role in terms of our body's vasculature and homeostasis and circulation. The way that it works is that it acts on guanylate cyclase to increase the amount of cGMP we have available to our smooth muscle, which then causes vasodilatation. So if you think about it, you have all of this increase in inducible nitric oxide synthetase, increase in nitric oxide, and so the shock that you get with sepsis is distributive. It's a distributive problem. Now, you can have some hypovolemia, right, whether it's insensible losses or the patient had a diarrheal illness causing their problems or they're taking decreased PO, but really the fluids that we are giving are to more augment cardiac output, get you to euvolemia. They're not actually dealing with the actual reason the patient has shock. So those early vasopressors, right, they get in there, they oppose these mechanisms that your inflammatory cytokines are getting going. They increase preload, right? You're just clamping down on that peripheral vasculature, you're shunting blood back to the heart, and thereby increasing cardiac output, restoring perfusion to the downstream organs to kind of improve your outcomes as opposed to have ongoing ischemia related to malperfusion. So there are a few studies out there, but the retrospective and the small prospective ones that exist do indicate that early vasopressors result in earlier shock control. So that means less time needed to be on pressors at all, and that with less fluid having to be given, a decrease in the positive fluid balance after resuscitation, and in some studies, decreased mortality. These all sound like good things to me. When they look at these studies in terms of adverse events, you're not seeing a bunch of adverse events associated with it. And then if you kick back to the Clover's trial that came out last year, right, it was looking at restrictive fluids versus early vasopressors, and those were given all peripherally. Peripheral vasopressors have been demonstrated to be quite safe. Not a lot of infiltration, not a lot of negative outcomes or distal ischemia associated with it. So I don't really think there's a whole lot of controversy, actually, associated with early vasopressors. I think that they have a very clear reason to be given. There's been not necessarily a mortality benefit every time you look at a study, but I think there's something to be said for decreased positive fluid balance, which has been demonstrated to have negative outcomes in patients with septic shock after resuscitation, as well as a shorter time of shock duration. So I'm not really waiting for more randomized controlled trials to start them, although I will be appreciative when they come out. I think you can go ahead and get those started. I'm going to get them, not wait for all of the fluids to go in to see if those work, but do them in conjunction. And I'm not really going to hesitate in starting those pressors if that patient in front of me doesn't look particularly fluid responsive or if they look like they're volume overloaded. All right, let's move on to methylene blue. I think as emergency medicine providers, what we're most familiar with when it comes to methylene blue is perhaps the poppers, right? So poppers, inorganic nitrates that are used to enhance sexual pleasure, but often associated with chocolate blood, methemoglobinemia. Maybe it's not the tox part, the congenital methemoglobinemia. You guys may be familiar with the famous fugates from Kentucky. So we're all used to methylene blue in terms of toxicologic therapies and methemoglobinemia as well. Why did we start thinking about it in sepsis? Well, again, I'm going to kick you back to this slide where we talk about your nitric oxide synthetase and how nitric oxide works. The way that methylene blue works is it actually inhibits that guanylate cyclase, so you do not get the downstream increases in cGMP, and you get less of that vasodilatation. But it also works to directly inhibit the inducible NOS. So you have two mechanisms by which your methylene blue is sort of fighting against the endothelial dysfunction and vasoplegia that you get with a distributed septic shock. Now, when did we actually start putting it into practice? Well, the literature that we have looking at methylene blue in shock actually comes out of our cardiac surgery literature, where we've seen lots of success in reversing cardiopulmonary bypass-induced vasoplegia, as well as increased survival, especially if that methylene blue is given early in the course. In terms of septic shock, there's really only a few prospective studies, but they're all pretty good at demonstrating that methylene blue is good at raising blood pressure and decreasing vasopressor needs. Not really so much in terms of a mortality benefit. And so there are a couple of reasons why this might be. Again, very few studies out there with methylene blue, but also a lot of heterogeneity in how things are given. Very commonly, especially even now when we talk about using it, methylene blue is generally used as sort of like a Hail Mary. This patient's doing terribly, their blood pressure's in the tank, they're on multiple pressors, they're on bicarb, we're doing all kinds of things, let's add methylene blue. And so it may be that giving it late in the course when your patient's probably not going to do well anyway, you're not gonna see that benefit, and giving it early might be more helpful. The other concept you should know about in terms of methylene blue and septic shock is this concept of responders versus non-responders. So when you look at these studies and they compare the people who got methylene blue to the people who didn't and don't see a benefit, in a couple of them, if you parse down to in the group that got methylene blue, there were responders, meaning getting methylene blue allowed them to decrease their vasopressor need by about 10%, versus non-responders. There's actually demonstrated some benefits in those patients, the responders, compared to the non-responders, even if you don't see a difference between the methylene blue and the non-methylene blue groups. All right, so with that stuff in mind, actually last year, the first randomized control trial did come out looking at the early administration of methylene blue in patients with septic shock. It's more of a feasibility study, very few patients, so 91 patients. Single center, double blind. They put all the methylene blue, they put all the infusion bags in those nice opaque, you can't see that the patient's getting a bright blue infusion intravenous sets. And what they did was they randomized patients to receive 100 milligrams of methylene blue as a 6-hour infusion daily for 3 days compared to conventional care. Now, their primary outcome was the time to shock resolution, so when they would be able to discontinue vasopressors in 28 days. And they had secondary outcomes of vasopressor-free days, ventilator days, ICU hospital length of stay, and 28-day mortality. What they found was that in the methylene blue group, there was a shorter duration of shock. So 69 versus 94 hours. There was one more vasopressor-free day. These are all statistically significant in the methylene blue group. Lower cumulative fluid balance to the tune of about 750 mLs of fluid. Shorter hospital and ICU length of stay, so 1.5 to 2.5 days. But with all these good things, no mortality difference. Now again, feasibility study, 91 patients, not necessarily the end-all be-all, maybe not surprising that you see a mortality difference. Some reasons that may come into play involve the dosing strategy. So we've already talked about sort of the heterogeneity involved in methylene blue studies. When do we give it? Who gets it? Why? But we're also not really clear on how it should be given. How much should patients get? Some studies use weight-based dosing of 1 milligram per kilogram. Some use 2 milligrams per kilogram. Some, like this one, use a set dose of 100 milligrams. Some give it as a bolus. Some do it as an infusion. Some do a bolus and infusion. So it's not really clear what the best way, what's going to give us the most optimal outcomes. There's a smaller study. This one's out of Prague, so this ICU there is very familiar with methylene blue. They use it as part of their standard operating procedure, but there's variance in how they use it. Again, some of them do bolus, some infusion, some bolus and infusion. So just a retrospective cohort study, didn't control for anything. And what they saw was that blood pressure did indeed go up in all of these groups. Vasopressor requirements came down. There was no control group of any kind. They just compared the 3 methylene blue groups with each other. No difference in mortality between the bolus and the infusion groups, but they did see in the group that got a bolus plus infusion, the mortality was decreased. So it's about 75% in the 2 groups and about 53% in the bolus and infusion. Now going back to Dr. Chan's lecture, correlation, causation, but just something to think about. This is really sort of the only real guide that we've had so far, or essence of a guide to how the dosing strategy could potentially go and be different between patients. All right, if you are going to use methylene blue, it comes with a warning, right? This has been known to cause serotonin syndrome when used in conjunction with other serotonergic agents. So if your patient needs to be on linezolid, is staying on linezolid, maybe they're not the right ones, they have a lot of SSRIs or other serotonergic medications, you have to be mindful of that. And then you cannot use it in patients who have known G6PD deficiency due to a possibility of inducing hemolytic anemia. I will say that the studies we do have using methylene blue in all these patients, they are not sitting and getting a G6PD test before administering to everybody, and you're not seeing large swaths of hemolytic anemia. So if you're thinking about it, maybe if you have a particular risk or they have a family history, that's going to be somebody who's you just say, okay, no. But otherwise, it's been relatively well tolerated. All right. So what's the take home on methylene blue? I think that you can use it for some patients. It makes sense to use for some patients. I think we do repetitively see decreased shock duration, and I think that that's a good thing. It's patient-centered, even without this a clear evidence of mortality benefit. And so should it be given to everybody? That's a question that remains. I think probably where it will serve you the best is those patients who have a clear control of their infection. They're on the appropriate antibiotics. They're on pressors. They just need to buy a little bit of time. So this is maybe going to be your profound urosepsis with septic shock due to a chronic Foley catheter that you have removed, you've changed. They're on the appropriate broad-spectrum antibiotics. They just need a little time for their body to kick in, for everything to kick in, their body to heal. As opposed to your septic shock of unknown etiology, or maybe your profound pneumonia that's not going to clear up very quickly. I think there should be some consideration to definitely giving it earlier rather than as a Hail Mary based on the literature that we do have. And I don't think the evidence that we have mandates a certain dosing strategy, but since we don't know that there's a difference between it, I will probably, if I use it, think more heavily about giving it with a bolus and infusion. All right? All right, beta blockers. Beta blockers in septic shock sounds a little counterintuitive, right? We give beta blockers to decrease blood pressure. We give it to decrease heart rate, which could be a problem if somebody's having a compensatory tachycardia, right? They're trying to make that cardiac output happen. So why would we use beta blockers in septic shock? Well, there is some thought and some understanding, pathophysiologically, there is a large sympathetic surge, right, with sepsis and septic shock, which is probably augmented/worsened by the catecholamines we add to augment blood pressure, so our norepinephrine or other vasopressors. And we do see a stress cardiomyopathy associated with some of our patients who have septic shock. So the thought is that if we use beta blockers, particularly cardioselective, so focusing more on heart rate than blood pressure effect, to sort of decrease that myocardial oxygen demand, we can mitigate myocyte damage and maybe decrease the likelihood of stress cardiomyopathy or worsened outcomes down the road. So that's one part. The other part is, as we've already discussed, sepsis is this huge dysregulation in your body's immune response. And a lot of that, while there's some anti-inflammatory stuff floating around, is pro-inflammatory. And that has a lot to do, that is highly involved with your beta adrenergic system. So the adrenergic system kicking in to modulate how the immune system is working. And this is through various mechanisms. They're all over the place. I'm just going to tack in a couple here. So endothelial dysfunction related to clotting dysfunction with platelets and fibrinolysis. So you're seeing a lot more endothelial damage, maybe more release of that nitric oxide synthetase and nitric oxide action. Sepsis is a catabolic state, so blocking that beta adrenergic component where you have less protein muscle breakdown, less impaired glucose metabolism, as well as less immune-mediated like lymphocyte apoptosis and cell dysfunction. So those are some things that the beta adrenergic system is involved in, and so if you can give a beta blocker to help with that, you may be able to improve outcomes down the road. So some of that pathophysiologic stuff kicking in as to why somebody might think about giving somebody a beta blocker. And of course, we didn't start with people. So there are some animal studies out there where they induced models of septic shock, and they gave these animals beta blockers. And in the animals who were treated with beta blockers, they actually saw decreases in myocardial dysfunction in some studies. They saw decreases in inflammatory marker levels and subsequent downstream organ dysfunction. And in a couple of these studies, they actually saw increased survival. Again, just animal studies, but some more signals out there for some potential of benefit with beta blocker use. Kicking it over to humans, when they looked at patients, there's a couple different studies. So when one study looked at patients who came into the hospital and they had septic shock, patients who were on chronic beta blocker therapy at home, actually, correlation, causation, actually had a lower mortality rate. Other things going on in that study, but this was an independent factor. So then people moved ahead and said, well, let's look at continuing those patients' chronic beta blockers, despite them being in septic shock and on vasopressors. And again, other things going on, but that patient cohort decreased mortality if those things were included. So everybody's like, oh, this seems like it maybe has a little bit more potential. Now, a little bit of terminology just to remind everybody, right? So when we talk about cardioselective, we're talking about beta-1 selective, again, focusing more on heart rate, whereas the non-selective beta blockers have that beta-1 and beta-2 activity, so that beta-2 working more on smooth muscle and can have more effects on your vessel tone as well as other regions in the body. And then, of course, there's short-acting, which we're more familiar with using. We feel a little bit more comfortable using due to the rapid off-of effects as opposed to the longer-acting beta blockers. So esmolol is the short-acting cardioselective agent that we are familiar with here and we use here in the US. So what do we know about esmolol in septic shock? Well, a randomized control trial in 2013 actually looked at randomizing patients to receive an esmolol infusion, and the primary outcome was if they could decrease the heart rate. So so patients with septic shock on norepinephrine with a heart rate greater than 95, could they bring it down to 80 to 94 effectively? The answer to that was yes. One of the secondary outcomes was 28-day mortality, and they saw a benefit to survival, decreased 28-day mortality in the esmolol group. Wow, sounds great. Why aren't we using esmolol in everybody? Later in 2021, another group sort of looked at, okay, well, we really want to try to mitigate cardiac myocyte dysfunction and stress cardiomyopathy. Maybe if we can start it a little bit earlier, we can really improve outcomes. We're going to use esmolol. These patients got, the esmolol started, I think the range was 6 to 12 hours, so an average of 9 hours after vasopressors were started for the septic shock. And actually, the esmolol group had more hypotension and decreased cardiac index. So no esmolol. Okay, all right, no esmolol. All right, another study comes out, randomized control trial, dual group randomized control looking at esmolol and whether or not it was going to be effective in changing vasopressor need. And essentially there was no difference. No difference between the esmolol group and the standard group, the placebo group, on how much vasopressors they required and how quickly their shock resolved. So esmolol, kind of all over the place. So meta-analyses abounded, and essentially this is what they all agreed on. Esmolol can control heart rate, may decrease mortality, may provide cardioprotection, we're not quite sure. All right, so that's esmolol, that's what we have here in the US. Jury's still out a little bit. Until you talk about landiolol. So this is an even more short-acting, so they call it an ultra-rapid-acting beta blocker, cardioselective beta-1, way more cardioselective than esmolol. It's used in the UK and Japan. They're very familiar with it, but we don't have it over here yet. And the reason we're talking about this, even though we don't have it here yet, is for our colleagues abroad, but also because the stress health study came out last year. And this study looked at the use of landiolol in patients with septic shock on pressors. So it's a parallel group, multi-center, open label, although the investigators were blinded to the study data while this trial was ongoing. And again, septic shock patients who were on at least 0.1 mics per kg per minute of norepi and had a heart rate of equal to or greater than 95 beats per minute. The intervention was a landiolol drip, titrated to get the heart rate down to 80 to 94 beats per minute. Primary outcome was an illness severity score, so a mean SOFA score, not particularly patient-centered, but that's okay. They did have some secondary outcomes of mortality, so 28 and 90 days, ICU and hospital length of stay, and then, of course, some lab markers for perfusion, lactate, oxygenation, ventilation. There were pre-planned interim analyses to sort of look at the data and what they had going on, and because of an indication that there was not going to be any benefit with landiolol and also that there was a trend towards mortality and harm, this trial was stopped early. So again, no difference in their primary outcome of SOFA scores with landiolol, a trend towards increased mortality in the landiolol group, and then more episodes of bradycardia, hypotension, and arrhythmia in the group receiving the landiolol infusion. So where does that leave us? Right now, I think you cannot, I personally think that with the data we have, we can't really be starting beta blockers in everybody. But I don't think that means that we can't ever. The heterogeneity that exists between what's happening in sepsis when, what exactly is happening in terms of the inflammatory mediators that are going on, the individual patient's cardiac reserve and where they are in their compensatory state versus leaning more towards that stressed state. There's a lot of interplay there, and it's not the same for all patients. So it's going to take a lot more studies, I think, to be able to parse out what subgroup might benefit from beta blockers, because it certainly seems like a subgroup may, but it's certainly not at the point now where in the ED we're going to be starting esmolol for patients with septic shock. In the MICU, I'm going to be starting patients on esmolol for septic shock. We're just not there yet. All right, so let's wrap it up. Take-home points. Early vasopressor initiation, not a controversy for me. You know, decrease your shock time, decrease the amount of fluids you need to give patients. You can certainly start it with fluids if it's indicated, and you might have some improved mortality. Still some data to come out about that. I'm excited to see it, but I don't think you necessarily need to wait for it. In methylene blue, probably some patient populations that would be appropriate in now. Definitely consider giving it earlier rather than as a Hail Mary if you're going to. Not enough data to support giving it to everybody, so you have to be a little bit picky and choosy, and exactly how to give it is unclear. Maybe give a little consideration to that bolus plus infusion if you're going to use it, but I can't say you must do it that way, and not really sure what dose you should use either. So, vaya con Dios, good luck. And then beta blockers, they're really not ready for prime time yet. There may come a day, there may be a population, there may be a somewhere, some way, but right now, probably not in our patient's best interest to be giving it to everybody. And with that, I thank you all for your time and attention, and I'll kick it back over to Dr. Winters.
Thanks, Dr. Hu. I do know that a few questions have come in. Move over to Dr. Miller, I think predominantly around the methylene.
So like, I know there's like no standardized dosing regimen, but a lot of people are wondering sort of what dosing regimen you use. What is your bolus dose? What is your infusion rate?
That's a good question. And so honestly, I would say I don't use it that frequently. When I do use it, I look it up. So completely honestly. So now I think you could, if you wanted to go more with the bolus and infusion strategy, you could kick back to that study and look at how they were doing it in Prague. That's certainly very anecdotal and one center centered. What some people are doing is an infusion of, I want to say it's like a set dose of either 100 to 200 milligrams of a bolus, and then continuing the infusion for some set period of time, 4 to 6 hours at around 25 mics per kg per min. But again, I have to look it up every time. I don't actually have a set dose.
And then we also had some questions from Satya as well, who's in the audience. He was wondering if you have there's any literature about potential methylene blue responders versus non-responders, like what features of a particular patient might make them more or less likely to respond.
That's a really good question. I can't say looking at the small studies that I pulled out that they really parsed down into that. That's not to say they don't exist. I did not dive off into that lit search, but in the ones that I looked at, I didn't see that they really divvied that up.
And then we know this was a sepsis talk, but any other alternate shock indications for methylene blue administration?
Well, if we have any toxicology people out there, it's good for all kinds of tox stuff, actually, which is nice. and then cyanide toxicity and all those other things. It wasn't really one of my controversies, but I think something coming down the pike for people to think about is the use of hydroxycobalamin, so vitamin B. There was a study that came out about that recently in shock. A little bit more expensive, but if you got to go something colorful, you can either do blue with methylene blue or you can go bright red with vitamin B12. But I think that one's coming down the pike, and we'll be talking more about that in the future.
Well, thank you so much, Doctor. I appreciate it.
Yeah, thank you.
Well, thanks to Drs. Chan and Hu for bringing us up to date on bicarbonate, along with some key things with respect to sepsis controversies. We are up at our second break, so we've got 20 minutes break, and then we're going to finish out our critical care symposium with a few other controversies. We're going to talk about steroids in critical illness, and then lastly, we're going to switch to the traumatic critically ill patient and talk about REBOA, ECPR in setting of trauma, and then cryoprecipitate. So we will see you in about 20 minutes.